Okay, good afternoon, everybody. I'm just going to make a start because I think the numbers of people joining the course stabilized now. So a very warm welcome to all of you. Thank you very much for joining today. I know diaries are busy, so it's great to have so many of you on the call today. What is the ePrescribing Masterclass? For those of you who haven't joined the Masterclass before, this is a monthly webinar where NHS organisations can share their learning and experiences of digital transformation to help support others. The platform aims to break down silo working, create a community, and enable other trusts to learn from each other. Let me just introduce myself. My name is Hoyan Senya, and I'm joined here with Amna Kampatel. We are both Chief Pharmaceutical Officers, Clinical Fellow, working at our host organisation, NHS England, this year within the Digital Transformation Directorate. Very excited about the topics that we are bringing to you today. Before I start, a little bit of housekeeping. The setup for today, as you can see on the slide, is 2 sets of presentations. After each of the presentation, there'll be some time for questions. On your screen, you should have a Q&A, a questions box. So put your questions in there. It's great to have a lot of engagement. So this is just to stimulate the learning and create some discussion about the topics. Certificates of attendance will be sent after the webinar. And if there's a topic you'd like to present on, please get in touch with Sarah, and her details are in the invite email that you've got. So the first bit that we're going to present on is Colin. We've got Colin Jones on the call. He's the Head of Pharmacy Digital Improvement and Innovation, and he's joined today with Hannah. She is the Digital Transformation Lead Technician, and they both work at Midlands Partnership University NHS Foundation Trust. The topic that they're going to present on is electronic prescription service in secondary care, and I appreciate that it is quite a new concept. The Trust was actually the first in secondary care to have EPS, and they've implemented this in March 2022. After that, 6 or 7 trusts have followed their footsteps. The hard work they've put in won them an award at the Digital Leaders in Sustainable Impact category, and I think that was last month. They're also nominated for 2 HSJ awards, one on net zero and one on mental health impact that the EPS in secondary care can bring. The project had huge operational benefits, and obviously from a sustainability impact, it also reduces carbon emission and support the digitalization of prescribing and reducing paper. So it's great that they're celebrated with this award, and it's something that we probably haven't really highlighted in all masterclasses to look at it from a sustainability lens. So with that, I'll just hand over to Colin and Hannah, please. Welcome.
Hi, yes, thank you very much. If you could, brilliant, thank you. So yeah, my name is Colin Jones. I'm the Head of Pharmacy Digital Innovation and Improvement in MPFT. I'll just pass you over to Hannah to introduce herself.
Hi everyone, I'm Hannah Wesley. I'm the Digital Transformation Lead Pharmacy Technician, also at MPFT.
Well, can we have the next slide, please? And the one after. Brilliant. So today we're going to give you a bit about the background of EPS and MPFT. We'll talk a little bit around the digital transformation journey from the first of type onwards. We'll sort of highlight some of the observable benefits we've had as part of our journey. Then what we're going to do is we're looking ahead at what we're going to do with EPS next. We're going to go through some of the shared learning that we've had around the positive impacts that EPS has had both for our prescribers and our service users. And then sort of the final leg of the presentation will be just to sort of highlight and show you guys some prescriber feedback we've had and some service user feedback, followed by some questions, if that's okay. So if we could have the next slide, please. So MPFT is a mental health and physical health trust. We cover 1.5 million population across 2,500 square miles. So we go down to services all the way down to the Isle of Wight. And previously on paper, we sort of did around 82,000 paper prescriptions in the community end. And before we did EPS, a lot of the sort of feedback we're having from prescribers in particular, but also admin staff, was around the writing of prescriptions, but then them having to travel with them to either other sites or clinics or to the pharmacies themselves so that the patients or service users could collect their medications. And obviously this was taking a lot of their time out of their day to do this. Obviously, again, the other sort of impact was service users having to travel to sites themselves, some of which didn't always drive or didn't always have transport to collect. So there was a sort of impact to the service user as well as staff around travel time and travel costs. Due to the nature of sort of prescribing with paper, when it was posted, we had a lot of sort of lost and stolen prescriptions where they had to be reissued, along with eligibility issues where the pharmacies or the local pharmacists to us would have to then ring the prescriber to clarify before they could dispense, along with a lot of duplicate recording processes. So one of the processes that some of our prescribers used to do was they would write the prescription, but then they'd have to write into the main EPR what they've just written on the prescription and save that before they hand the prescription to the service user. So there was a lot of sort of need here and a lot of feedback from our prescribers around, is there a way to digitize? And obviously COVID had a massive impact on this as well around sort of the urgency to digitize this sort of paper process. Could we have the next slide, please? So from a trust perspective, we started working with the clinical and the digital teams within the trust to collaborate around sort of looking at what we needed to do. And then we started working with the supplier of the system called Clio and NHS England, and we did a first of type scheme in March 2022 till May, where we piloted this across 3 of our services. And we were the first in secondary NHS care for EPS. A lot of this was around process mapping. So looking at our current services, how do they currently prescribe, what is the process, and then mapping that against the system that was available to see what the sort of fit was. And obviously we'd done a lot of service process mapping. Some services fit really well and some services didn't fit so well. And it was all based, the process mapping was all based around trying to make the fit as perfect as possible. Obviously never perfect, but as perfect as possible so that the transition would be more smoother. What I would say is the process mapping thing was probably the most important phase of this deployment across the whole of the deployments we've done, to make sure we're matching how the service works around how the functionality of the system works. And then since sort of the end of the assurance, successful assurance back in sort of June or July 22, we've sort of onboarded another 17-ish services. So we've got services such as adult mental health, children's mental health, sexual health, community rheumatology, perinatal, all come on board as part of this. Now, some of the services use it fully and some services only use it partially because of the functionality itself. And then we were quite delighted to work again with Clio and NHS England around one of the functionality limitations, because as a trust, we are a physical and a mental health trust. We merged back in 2018. The system that we have works very well with the mental health ODS codes. However, it didn't work with the sort of physical health Y codes. So we were really delighted to work again with Clio and NHS England back in December to do another first of type to enable that functionality to allow physical health services. So we did cardiology or heart failure and diabetes as our 2 services. So again, we process mapped them, did the first of type with the assurance with NHS England and Clio systems, and we successfully completed that just before Christmas. So that functionality now has unlocked our ability to be able to potentially onboard another 500 to 700 staff. Could we have the next slide, please? So I just wanted to show you, this is a screen print off the supplier's website, just to show you the sort of medication end of the system. I won't spend too much on this because it is just a screen print that you can get off their particular website if you want, but that's the sort of level of detail we can get for our prescribers to prescribe. So you've got the search of the medication, the derivative, and then you can put in the quantity and the dose instructions. So I won't spend too long on this. I just wanted to show you an example of how that would look. So if we could have the next slide, please. So looking at this, we've done a lot of benefits realization on this. So currently we've got around 340 prescribers using this system. And I'm pleased to say that this week we've hit 100,000 electronic scripts. So it's a massive achievement for the trust. when we're talking around the sort of background around the necessity for the need for this, we've been able to measure that as a result of putting EPS in place, and from feedback from our prescribers, it's avoiding them traveling 4,000 miles a week and 2 to 4 hours worth of their time of travel as well. So that's avoiding having to literally deliver prescriptions either to basis sites or pharmacies. And obviously there's an associated CO2 saving from that. So we've been able to measure based on weight of paper and things, what that is, which is 1124. Similarly to the service users, so we did a bit of a methodology around how far a service user typically would travel to collect a prescription. And again, we were able to sort of measure that we're avoiding around 1,500 miles for our service users a week, and again, 372 kilograms of CO2. The other sort of benefits we started looking at was sort of a time and motion around how long it would take on average to process and write a paper prescription versus EPS. And as a result of that, we've worked out we've saved around 146 hours from the use of EPS instead of handwritten, which is fantastic for our prescribers, because what a lot of our prescribers are saying is they're able to see more, be able to have more appointments in the same clinic times because they're not having to stop and deliver prescriptions. Or particularly for our physical health services, they were saying that they sometimes would have to cancel a clinic to deliver paper prescriptions for service users. And again, as you guys probably know, if you had to post a prescription, we've sort of worked out we've saved around 35k up to date with the avoidance of that, because an EPS prescription by its nature is digital. And because it's digital, there's no postage needed on that. And again, as you can see from the screen there, we've done a bit of an analysis on our incident management system around incidents logged as a result of paper FP10s. And it's really pleasing to see it's come down by 55%. The majority of that 55% is lost, stolen, where obviously if it was lost or stolen, it'd have to be reissued, it'd have to be logged and tracked. So it's really pleasing to see those sort of tangible benefits coming through. If I could have the next slide, please. Other sort of tangible benefits we've got is it's allowed our prescribers to do more remote consultations and prescribing. So there's been examples of where some of our service users have been on holiday in Cornwall, they've lost their medication, and they could have a replacement within a couple of minutes, which is obviously the one below. As I say, the prescribers have said they're able to see more people in the same clinic slots because they're not having to take time out to travel and deliver paper prescriptions or get them processed. EPS allows also more timely reporting than EPAC. So I know EPAC's a couple of months behind, but with the data feed that we receive, we get prescribing information the day after. So we're able to really analyse the prescribing activity, as well as it records things such as the dose instructions as well. There is a button within the system to be able to copy what you've prescribed and add it into the EPR system. So this goes part way towards some of the feedback from our prescribers of this dual entry of writing a prescription and having to write it into their clinical system. And with the nature of EPS, you can also cancel the prescription digitally as well. So if you've made a mistake, you can actually cancel it and reissue within a couple of minutes. So next slide, please. So I'm just going to pass you over to Hannah just to complete this off. So over to you, Hannah.
Okay. So here we're just looking ahead at the things that we're planning to do in the future. So we've got a new upgrade that we are currently working on now, going live in the next few weeks. So this is going to bring in some more enhanced functionality for us, especially including GP Connect. So there'll be an integration to add GP Connect to EPS. So as long as the patient provides permission, the prescriber will be able to see their medical history and their information as they're prescribing at the same time. It's also going to include a nominated pharmacy selection. So that nominated pharmacy that the patient has already got, that will show up on EPS, so that can automatically be selected, so that any medication could go straight to that patient's requested pharmacy. There'll also be some more enhanced functionality in there, some configuration options to do with Latin abbreviations when you're prescribing. We're also working on a RIO interface with EPS. So EPS is our electronic patient record. RIO is our electronic patient record here at MPFT. So what we're planning on doing is having a click through straight from RIO, from our patient record, straight into EPS, so that the prescriber doesn't have to search by NHS number and date of birth again. That information is automatically pulled through from Rio into EPS, and then they can go ahead, prescribe the patient's medication. Once they've completed the prescription, that information will automatically get pasted through into a progress note into Rio, so that other clinicians can then see that information, and anyone who's involved in that patient's care will be able to access that information straight away in the patient's record. We're also doing some work on bringing in some physical health services. So this is another first type we're working on, where we're able to bring in these physical health services. So that will help us to bring in another 500 to 700 prescribers into EPS. And we're also working on One Health and Care integration, which would then mean that any prescribing information we have on EPS, other health prescribers will then be able to see that prescribing activity. So for example, the GPs can then look at that in the GP practices in our local area. And we are also the first of type in repeat prescribing. So this is going to be another piece of work that we're currently working on with NHS England and Clio to get repeat prescribing straight into EPS for secondary care. Next slide, please. So here we just got some information on some shared learning that we're doing with other trusts, which is just creating a good positive impact. As we just find that it's so important to be able to share our learning across the NHS, so that we can work in collaboration with other trusts and make sure that this prescription service that we're providing is the best system for everybody to be able to use it. So as we've said, we're working with some other NHS trusts to be able to help get them on board with EPS and also develop their EPS service more. We've got some operational monthly meetings that we have set up to be able to share information with each other. And this is also helping us to gather, as you've seen in the presentation, we've gathered some benefits realization, and then we can see from these, we can see how we've been able to improve our service to the trust, particularly to help for patient care, patient mental health, and for sustainability impact. And we're also sharing information about our business case, our lessons learned. So any information we've gathered, we've gone to the prescribers, to the service users, and asked them what has gone well, what could be improved. And that's where we're using that information to then develop further and bring this even more functionality and these upgrades that we're working on with Clio. And also there, just deployment experience and any clinical safety considerations. So we're happy to share this with other trusts who are also on board with Clio's EPS. Next slide, please. And here we just got some feedback from our prescribers. Just we've just popped up a few different examples here of the feedback we've received from them. So I won't read them all out, but they're there for you. So for example, just the second one, software has been a game changer for the community practice, able to safely do prescriptions anywhere when covering such a large geographical area, which has been amazing. Because particularly with MPFT, we cover such a large geographical area that this has been a real game changer for us, that you can prescribe from anywhere. So I'll just leave that for a couple of minutes. And then next slide, please. And then this is just some more feedback again. This is directly from our service users. So the previous one was from our prescribers. Here, this is from our service users, from our patients directly. So that's just a bit of information we've got from them. The top one, so happy with this new service. I don't drive, so I'd have to catch a taxi to collect my prescription, which was very costly. So having it sent straight to the pharmacy is going to save me money. So there's just an example there of how we're helping our patients just to provide that better care, that better service for them, and help with their costs and with improving mental health as well. And next slide, please. Any questions?
Thank you very much. That was a really brilliant presentation. I think it's an absolute massive project, mammoth operation. I personally really like the last couple of slides where you can see some of the user feedbacks, and I know for sure that I'd love to have that in the Midlands here. It'd save me having to go and pick up my prescription for my little boy. So I know that Colin and Hannah has been very happy to work with other trusts to help them in this journey. With all the contacts that I've had previously prior to this presentation, they've always said, oh, we're always happy to help. So reach out if you want to be part of the operational meetings. I'll pop their details in the chat after this, so you can reach out to them if support is required. We were actually a bit nervous about not having enough questions, since it's such a niche topic to talk about. Well, we've got plenty you'll be happy to hear. So I think first question is, can you talk a bit more about the timeline, appreciating it's a first of type project that you dip your toe into? This is a question from Sarah Thompson. So they want to understand how quickly they can get on board and what the timelines could be.
Yeah, not a problem at all. I am trying to answer the questions as well as we're going along. It's a lot of questions. I think for us, the biggest feedback has been around working with some of the trusts who are interested around their business case, because they needed to write a business case, and obviously we've been supporting them with, especially around the benefits stuff, to sort of outline what that is. That's been the biggest delay for some trusts. I think if you've got the right staff in place and the right processes, and you work well process mapping with the services, it can be quite quickly deployed. But obviously that's subject to the suppliers availability as well, and obviously the ordering and the sort of procurement process.
Okay. So another question that might be touching upon that is that the supplier you used, was that already assured as part of the first type, or was that something that you had to work with them to get that done?
So we were the first type trust to work with NHS England and Clio to assure this product. Yeah, so we worked with them on that assurance, and then, as I say, we worked with them again last December to assure the Y code physical health functionality as well. So yeah, we were the first trust to assure it with those two guys.
Okay, let me pick out a couple more questions for you. One from Geordie. Geordie has presented on this platform before, so hi Geordie. What about home care patients? Would you be able to use the EPS to send prescriptions rather than to community pharmacy? Would you be able to send them to a home care?
So that's a really good question, really good question. So I don't know if you guys were aware, but back in October, November, there was a digital medicines first type scheme that was done via NHS England. MPFT was successful EPS wise in our bid to enhance EPS further with repeat prescribing. So we're just starting that journey to enhance EPS further with repeat prescribing. Another trust put a bid in for home care, and we're very keen to obviously see what the output of that is as well. I think the deliveries of both ours, which is repeat prescribing, and home care has to be delivered by March 25. So I'm hoping that if the other trusts get that done, we can also adopt it, because we do have home care as well. So currently it doesn't do it, but there's as I say, there's a digital medicines first type scheme funded for another trust to do that development.
Okay. Thank you. I'm going to pick up two questions from Leo Martin Scott. He's got a question about how information such as cost code, registration, basically the practitioner details are captured and shared within the prescribing service. So that's the first question. And then I suppose the second question is more about deployment. So what is the magic dust? What factor leads to areas working well versus departments of area not working well?
Okay, I think if I answer that one first, like I mentioned before, that the process mapping is the key to making this successful. When you process map your service against what the functionality of the system is, you'll see how much it matches. Now, with some services, it matches perfect and they work brilliantly. With other services, it doesn't quite match because of the functionality, and the service needs to make a call around, well, do we partially use it or do we not use it? So I think for me anyway, the important key here is around process mapping. With regard to the other question, we use Power BI from a reporting perspective. So we set up the users within the system with their prescriber code and their service. So as they're prescribing, it's recorded. And then nightly, we get a data feed with all the prescribing activity from that day. So we're able to report back the day after. Whereas I know there's a sort of limitation with the sort of BSA's EPAC of being 2 to 3 months. So we're getting a timelier reporting, if you like. So we can report on prescribing activity per prescriber or per service in a daily basis, I suppose you'd say.
Okay, that's brilliant. I think some of the questions, you have got a lot of questions, you have already answered within your presentation. Before I ask the last question, just to confirm, you're happy to look through the questions and feedback to all attendees?
Yeah. I have been answering some. Can you see the answers or not? Because I have been answering the questions or trying to while Hannah was presenting. Mine are in sort of a purple colour, the answer.
Oh, I'm not sure. I can't see it on my screen. I'm not here on your screen.
No, I haven't seen it, but maybe after we can copy them across, Colin, you know, with Sarah, just so that we can put them on the futures board.
Not a problem at all.
Okay. So my closing question for you kind of links on to our next presentation, which is on BCP planning, which is obviously quite important. What is the BCP arrangement around EPS and secondary care?
Yeah, of course. So there is an option to do an offline print from the system, but as a trust, we felt that obviously if the network goes down, a lot of our printers are networked, so you wouldn't be able to print. So our current BCP is that they keep one FP10 pad with them, and that's their business continuity. So they keep that with them. I mean, it's pleasing to say it hasn't gone down in the time we've had it. But yeah, they keep one pad. They keep one pad anyway because there are some functionalities and some scenarios where you can't use EPS, and I'll give you an example of one. We've got services in Oswestry, which is right on the border with Wales. So for the English patients, we can use EPS, but because Wales hasn't got EPS in yet, for our Welsh patients, they have to write an FP10. I know Wales is coming on to EPS soon, but it's just scenarios such as that where all staff keep one paper pad as their business continuity.
Okay. Okay. Thank you. Thank you, everybody who posted questions and interacted with us. Thank you very much, Colin, and thank you very much, Hannah, for coming to present today here. Best of luck with the HSJ nominations. We'll be following that from afar. Okay. I think I'm going to hand over to Anna.
Afternoon, everybody. I hope you can hear me. Apologies if there's some background noise. So our next speaker is Oliver Savage, who is an advanced clinical pharmacist at Leeds Teaching Hospitals. We met Ollie actually at the Digital Health Rewired last month on the Digital Allied Healthcare Professional Pharmacy Summit stage, and he actually presented on the forum something which perhaps we haven't considered enough in terms of how your organisation plans for unplanned downtime and how we can ensure that we can still operate when the unforeseeable things happen, and equally important, how we're going to keep our patients safe. So on that note, I'm going to hand over to Ollie.
Thanks, Amna. So yeah, I think as the title of the session said, yeah, it's a bit about business continuity planning. But yeah, it's essentially what happens when EPMA systems go down, and how do we prepare our staff for that occasion. So yeah, over the next 15 minutes, I'm going to talk about unplanned downtime and hopefully what you can do to reduce the impact of this on both patients and staff. So I'm the advanced clinical pharmacist for eMeds at Leeds Teaching Hospitals. So my role is I'm essentially a middleman between the clinical and the technical side to make our ePrescribing system safer, more efficient. Leeds Teaching Hospitals is a large teaching hospital, a large trust in North England. So we have over 2,000 inpatient beds. We have 700 staff within pharmacy, so we're a big department. So there's a lot of people and a lot of staff. So I think there's over 20,000 staff in the whole organisation. So a lot of people to brief and keep up to date. Just for context of what our electronic prescribing system is. So we have a homegrown electronic patient record called PPM Plus. And within that, we have our EPMA system, which is a product called MedChart, which is provided by a company called Deadless. So we have that kind of best of breed model going in within the organization. So my reason for undertaking this work was inspired by a conference that I went to a couple of years ago now, and it was a large focus on cybersecurity and ransomware. And as my colleague Matt and I were driving back up north, it got us thinking about the potential consequences of unplanned downtime. And it didn't take long for us to get pretty scared about what would happen if we lost the network, if we couldn't access it, and the absolute carnage that would cause. So yeah, it got us thinking, and we kind of thought if this happened to us, neither of us were really confident that our staff would know what to do. So yeah, we decided to do something about it. Next slide, please. So the dependence on EPMA systems has grown exponentially over the past 5 to 10 years. And while these systems have revolutionized patient care, they also introduce vulnerabilities, as demonstrated by the WannaCry attack in 2017, which I think was estimated to cost somewhere in the region of £100 million for the NHS. So consequences of unplanned downtime can be severe, and they will almost certainly have an impact on patient safety. So something that we really need to consider. The second bullet point highlights that healthcare staff have become increasingly unskilled in using paper drug charts due to their reliance on digital tools. So we implemented our EPMA system in Leeds back in 2017. And that essentially means that anyone under the age of about 30 may never have used a drug chart before, a paper drug chart. And we know that a significant amount of medicines are prescribed, administered, reviewed by those junior staff. And so it's therefore essential that these staff know what to do if systems go down. So yeah, over the next 10 minutes or so, this presentation aims to address the critical need for preparing staff to handle such situations. It'll outline how we did it for pharmacy staff within a large teaching hospital in Leeds. But hopefully, whether you're a pharmacy staff, whether you're nursing, medical, hopefully there's some kind of lessons that you can take out and learn from it. And even if you don't have much time on your hands, hopefully there's a few little tips that you can implement to try and help reduce the impact that it can have. Next slide, please. So simulating downtime is pretty tricky, and I was having to think about, well, how do we mimic this? And it would be completely immoral to just take the system down for a few days. We can't do that. And so I was having to think about, well, what do we do? So I decided to simulate some downtime by getting a few willing volunteers in a room, gave them a bunch of paper resources and asked them to go do their pharmacy thing. So I got a few pharmacists from different clinical areas and of different experience. So some of them had used paper charts before, some of them hadn't. Also got a pharmacy technician, got a nurse in there as well. And so I'd written out some paper drug charts. I'd printed out some of our business continuity charts, which we can generate from our EPMA system. I'd written out some EDANs, gave them some ordering forms, and just said, yeah, kind of go do your thing. Gave them a few scenarios basically. And I wasn't really sure how the session would go. Yeah, I didn't know, but I was like, let's give it a try. But actually, it was an absolutely brilliant way of identifying the gaps in our processes and working out what information I needed to brief staff about. Next slide, please. So what are some of the things that you might want to consider? So the first thing to mention is just to think about what systems are down. So depending on the cause of the the unplanned downtime, whether that be network failure, a cyber attack, server issues, etc. You might just need to think about what systems could go. So if you've got an enterprise system, so Epic or Cerner, then it's kind of, I assume it's all or nothing. Whereas if you're a best of breed model like us, then you might lose one aspect. So we might, for example, lose our electronic our EPR, but our EPMA system may still be up. So it's just working out the different scenarios. So what would you do if all systems were down? What would you do if only some of them are down? So just thinking about those things and thinking about some of the consequences as well. So although in pharmacy I'm not that, you know, for me, if the blood result system went down, it wouldn't impact me absolutely directly, but it will have an impact on the bigger system. And so just you need to think about some of those things as well. What do you do about electronic clinical notes? What do you do about if your chemocare system goes down, if your stock management system goes down, PAS, etc. So just have a think about other systems, not necessarily just your EPMA system. Other thing to mention is communication systems. So since COVID, our teams communicate in a very different way. So we rely heavily now on Microsoft Teams, and we use that to communicate within teams. So we ask people to follow up tasks, and we hold a bronze command session, like team meeting every day. So those things may not be available. How do you communicate with people? So where do people go to contact people? So just have a think about that. Next thing to think about is the different periods of downtime. So I've broken these down into different sections according to a few scenarios. So the first thing to mention is what happens in the first 24 hours. And my kind of key advice to people would be don't enact full BCP until you have to. So our EPMA system, if it goes down, then we have a backup laptop on every ward, which nurses could go to, and they can print out a paper drug chart of every patient. So that will show what medicines they've been prescribed and when a last dose was administered. So absolutely essential piece of kit to know what medicines a patient's prescribed. But it's important that if the system does go down, that nurses don't rush and print out 30 charts for every patient on the ward, because the system might come up in half an hour. And if that does happen, then you've got to transcribe all of those medicines back onto the old system. So if you can, finding out information about how long that period of downtime is likely to last is really important, because it can save you some work, basically. Our business continuity charts that we can print run up to 10 days, so there's space on there to record doses for up to 10 days. So in that, when it does go down, you can use those charts initially, but then over time, any new admissions, you may need to you may need paper charts and so on. So it's just thinking about that. And then after 10 days, every patient will need to have a paper drug chart. The final bit I've put on there is just about system recovery. So what to do when the system comes back up. It may be that you need to think about building rules into your system so that people can't jump onto it when it comes back up, because there may still be bugs, there may still be issues with it. So you may have to do some testing with the system to make sure everything's okay before you make it available to wider users. So that may be something worth considering. So I still need to do it, but I need to look at building a rule into our system which can prevent other users accessing the system in order to give our team a chance to test it before we make it available. The third box on there is just about thinking about admission and discharge processes. So what would you do if you couldn't access patient summary care records? You can't access what regular medicines patients are on. What about things like discharge medicine service? How do you send those referrals? How do you send TTOs to GPs, and how do you make GPs aware of urgent actions on discharge? So again, just some of the things that you might want to think about. Again, it can be quite overwhelming when I talk about all of these things. These aren't necessarily all of, don't feel the need to take all of these on your own back yourself, but they're just things to think about. And then the final thing that we thought about was clinical pharmacy provision. So having a think about, how is it that you're going to review patients? So in our current system, we have a kind of a dummy drug set up within our drug chart, which we use to set reviews. So if I needed a ticoplanin level following up in a couple of days' time, then I would set a review on that to ask a colleague to action something. Whereas that's not really possible in paper. So you need to think about those pharmaceutical care plans and how you might need to ensure that any actions that need following up get done. We also need to think about ordering medicines as well. So again, something that changed for us a lot in COVID is that over the past 5 years and since we've used paper charts, is that there's been a big shift so that now the vast majority of non-stock medicines in our organisation are ordered by either pharmacy support workers or pharmacy technicians. And a lot of that has been enabled because there's no transcription risk, so some of the risks of ordering medicines are lower. Whereas if you're going to have to transcribe and write out medicines order forms, then actually you may need to think about, is that something that support workers and technicians are still trained to do? Does it need to be validated by a pharmacist before that order can be sent? So just another thing to think about. Next slide, please. So I've tried to break it down into, I kind of want people to go away with some things that they can learn and take away and action in your own relevant trust. So I've tried to break it down into 6 key points. So the first thing to mention is any unplanned downtime is inevitably going to have an impact on patient safety, and the best thing to, although we can prepare for downtime, the best thing to do is just to prevent it happening in the first place. So reach out to your IT teams, whether find out who is responsible for cybersecurity, who is responsible. So we now have someone who's responsible for business continuity planning. They're a lead for the trust there. Find out who these people are and check, are these networks as resilient as they can be? What more can be done? And just making sure that the importance of keeping your EPMA system online at all times is emphasized to them. The next thing to mention is if you haven't yet got an EPMA solution, or if you're going out to retender, or you're looking at potential suppliers, make sure that those suppliers provide suitable contingency plans. So drill down into the detail. What is it that happens if those systems go down? So as Hoyan mentioned in the last session, what happens if EPS goes down? What is it that you're going back? What do you do? It's possibly a bit more simple for EPS prescriptions if it's just 1 or 2 items, whereas if you've got a drug chart that's got 20 medicines on it, then it can be slightly more complicated. So just make sure that you consider that whenever you're considering a new supplier. Third point is to review, or if you haven't got any, create some business continuity plans. So these should be really simple, straightforward flow charts or flow diagrams of what staff should do if a system goes down. So who do you contact? Where do you meet? Where do you keep a supply of all your paper drug charts? So have a think about some of those. They should be accessible and easy steps to follow. Fourth thing I've put on there is if you're lucky enough never to have experienced some downtime, then try and, but you know that trusts that have had downtime, then go and reach out to them, speak to them, and learn from those organisations who have had downtime. So we're really lucky that there was a trust that also used our EPMA provider. They had a 2-week period of downtime, and I asked them to come and speak to our user group to kind of go through their lessons learned, and that was absolutely invaluable for us to learn about what went well, what didn't go well, what are the things that you hadn't factored in. So so that's just worth something doing. Or if there's similar sized organizations or organizations that use the same sort of EPMA, there's no need to reinvent the wheel here. If you can ask for someone's a copy of their BCP plans, then send them through. Fifth thing on there is to run simulation sessions. So every trust, we're a national health service, but we're not. No one organisation is the same. So I highly recommend running a simulation session. Get a wide variety. Get half a dozen people in the room, different experience, different clinical teams. Get them in a room, because although you'll be able to think of a lot of it yourself, actually you won't be able to think of all the different factors. So getting other people in there and bouncing ideas off them is really useful. So in the simulation session that I did, I gave everyone a just some post-it notes, and if they had any questions or queries as they went along, they wrote it down on bullet points, and then we stuck them on a board after and went through them, and that helped us to kind of really ensure that we kind of covered all aspects of it. And then the final thing on there is to make sure that all of that plan that you've done is pushed out to the staff. So make sure that you brief your staff. So I held two, I kind of pulled some slides together on kind of the key bits of information for them to be aware of, and then held two face-to-face sessions and some team session on what staff should do. I also made sure that those key documents were in a place that is easy to access. So if you've got a Teams channel that you normally have information on, consider dropping the files in there, because if your iDrive goes down, then they're available there. Or if you've got a remote dispensary, put paper copies of it there so they can photocopy bits if the whole digital system goes down. So it's just thinking about some of those things, and briefing stuff can be really useful. Next slide, please. So that's a very brief overview of preparing for unplanned system downtime. I think that I haven't gone into too much about the consequences of it, but hopefully the WannaCry incident and another downtime instance have underlined the urgency of preparing staff for downtime. Hopefully I've highlighted the importance of investing in staff training and education, the importance of simulation sessions, and strengthening cybersecurity measures. And I think by doing all of those factors, we can ensure that patient care remains uninterrupted, even in the face of unforeseen circumstances.
Thanks, Ollie. Thank you for the presentation. You've definitely given food for thought for people to consider in terms of what to consider if there is unplanned system downtime, which obviously you've highlighted some tips there for people to have a look at. There is a few questions in the chat box, so we've got a few minutes just to go through a couple of them if you're happy to.
Yeah, of course.
So one of the questions is around how do you ensure that downtime is owned operationally by staff rather than the digital pharmacy team?
Yeah, good question. Well, I think it's that thing of it's everyone's responsibility, and I think one of the things that our staff were in the briefing sessions that I did, our staff were engaged really well on it. But one thing I would, if you were struggling with that, then I think at the end of the day, everyone's a registered professional, so it's their professional. Well, a lot of staff will be registered, so it's their professional registration that's on the line. But the other thing is, there are patients at the end of this, so they should be, whether that be if that was a family member for them, friend, etc. Downtime, it will be absolute chaos. If you lose your system, it will be chaos, and there will be harm that come to patients from it. So the onus should be on them to kind of educate themselves as much as they can. If they want to do it as a bit of CPD, do it as CPD. This is just as important as learning about a new type of hematology drug that comes out if systems go down. So yeah, that's what I'll say to that.
Yeah, and another question was about, obviously this presentation was about unplanned downtime, but there's a question about if any considerations in the business continuity plans were for planned system downtime, for example, maintenance. Is that part of the business continuity plans that you have in place?
Yeah, so it just depends really on what, so yes, it is. Most of it is relating to unplanned downtime, because generally your planned downtime, we will schedule it out of hours, so between 1 AM and 5 AM. So the system's not likely to be needed that much. But yeah, absolutely, there'll be a lot of principles that are the same for planned downtime. Yeah, there's planned downtime, you just get a bit more time to think about stuff.
Yes. And then we've got a question about, have you experienced any issues with using a normal printed paper as a drug chart for prescribing and administering compared to the usual drug charts that are thicker and the Cardex version? Have you experienced any problems or issues with those?
Yeah, so that's a really good question. That's one of the things. So yeah, I should have mentioned it. And it's one of the things that we did is when you print out your chart, actually go through them with a fine tooth comb and getting people to use them in the simulation session, prompt some questions. So one of the issues that we had was in our charts, when you print them out, it has a prescriber name and then has a space for them to sign it. But we weren't. But if we went into BCP, then we wouldn't ask prescribers to sign it because they've already prescribed it essentially. And if we had to rely on a prescriber going around and signing every medication, then nurses wouldn't be able to give medicines for hours. So that was one of the things that was a bit ambiguous and something that we needed to clarify. So yes, there are issues with BCP charts. The other thing is there might not be space to document how you've ordered a medicine. Yeah, a few different things. So yeah, you do need to have a look at those BCP charts and have a look, is there anything missing on them? Other thing is as well is that kind of at some point you're going to have a hybrid model. So that BCP chart will only have space to record X amount of medicines. So you'll need to start using a new chart if medicines are stopped, if medicines are newly started. So you'll need to just think about yeah, how you manage those, and at what point does the BCP chart just look a complete mess and you need to cross through it and transcribe it onto a new one. Yeah, something to think about.
And there was a question now about who decides that wards should go to paper charts. Is it a centralized decision? Because I think there was a comment about it's very difficult to take the decision if the reasons for being down is not clear, so you don't know how long you're going to be offline for. Is it 20 minutes? Is it an hour? At what point would be the appropriate decision to say, actually, we need to switch, to paper?
Yeah, again, really good question. So at Leeds, we have it. So if the system went down, then a bronze or a silver command or whatever kind of command system you get set up is likely to be called. The matron for each area, or basically the head of nursing will make that call to say, yeah, we need to enact BCP, and then that will be disseminated to the wards through the relevant matrons. But again, it's really tricky because, as you've said, one, you often don't know how long that downtime is going to be. So making those connections with DIT staff so that it can inform you, or this is the cause, or we think it's going to be out for that long, that can help make that decision. The other thing that you need to think about is, you are likely, no matter what area you're going to be in, there are going to be patients that have time critical medicines, or they might need pain relief in a timely manner. So for those patients, I've always just said to staff, if there are patients on the ward that need medicines, then absolutely print charts for those patients and give medicines. But there's no need to do it for every patient. Don't do it for every patient until you have to. So kind of try and hold your nerve as long as you can, basically, because if you don't, then you just create a load of additional unnecessary work for yourself later on down the line.
And a final question is, how do you ensure users are aware of the business continuity plans?
So just, yeah, about briefing staff really. So, and again, one of the downsides to what I've done is that I've only done it for pharmacy staff. So I haven't gone into nursing or medical staff. So yeah, it's kind of, I didn't want to bite it off more than I could chew really. But doing those briefing sessions with staff is important. The other thing is you can look to build it into mandatory training. One of the other things you can do as well is look at building it into ward metrics. So every month all of our wards are required, the ward manager is required to do some metrics about a range of different things. So adding BCP onto that is really important. So we need to make sure that, are they checking that those laptops still work? Do the charts still print out? Are staff aware of the process? So in all our wards, the process is stuck to the inside of the controlled drug cabinet, because we know that's not going to go anywhere. So yeah, that's kind of how we get the message out to those staff. Medics wise, I honestly don't know. It'd be carnage. Yeah, something to think about.
Thank you so much, Ollie, for joining us today with the presentation. I think there's a lot of things that the attendees can take away and have a reflection on and see what they want to do. Yeah, thank you everybody for engaging with us, posting questions as well. I think most of the questions have been answered, but Ollie has said that he was happy to answer any questions offline. Next slide, please. So I think we've come to a close for this session. Thank you all for attending. Our next masterclass is on Wednesday, the 15th of May. A reminder will follow if you've signed up through Sarah. If you've got any ideas on future topics or would like to feedback, please either scan the code or reach out to Sarah. Her details were in the invitation. Was there anything else, Amna?
Yes, sorry, apologies for the noise. The certificate will be sent after the event for attendance. And also, as Hoyan said at the start of the session, if anyone would like to present, please do get in touch, or if there's any ideas for subject matters that you'd like to be covered in the masterclasses, again, let us know.
Okay, thank you very much and enjoy the rest of your day.
Thanks everyone, bye.